Thanks very much, Gene, for the warm welcome. And it's great to be able to spend an hour with you talking about what I think will be hopefully some interesting as well as some difficult issues. So we hope to have like an honest discussion about health equity and disparities. Komarso toko inwa, he takuta aho no Chicago, konoko toko hua huahini, kotoshi toku tama, ko nursnak te mona, ko walden te roto, ko nyata hainamana me nyata America nya iwi, tena koto katwa. My name is Marshall. I'm a doctor from Chicago. Naoko is my wife. Toshi is my son. A nursnak is the hill. Walden is the pond. I am Chinese and American. Greetings to you all. So that's my mihi, which is a Maori word. Maori are the indigenous peoples of New Zealand, or Aotearoa as they call it, in New Zealand. And I was told that it's a cultural tradition in Maori as well as in the wider New Zealand culture to begin a formal talk with your mihi, which is my personal introduction. So I spent the summer of 2017 in New Zealand, and I lived in a freshman dorm surrounded by 400 freshmen at the University of Otago, which believe it or not, I actually enjoyed. And in the left here, this was a piece of artwork that was overhanging the dining hall where people had all their meals. And it's the hawk kite, which represents the three different foods in that area of New Zealand. There's shellfish, there's fish, and there's bird life. And it was meant to have deep symbolic meaning being there in the dining hall, and that there was going to be nourishment of the physical body at the dining hall, nourishment of the mind, because in the dining hall that's where you will have a lot of discussions with your classmates, as well as nourishment of the spirit, a place to congregate, a sense of community there in that freshman dormitory. These are three of the young Maori students who taught me my mihi and helped me coach me through it. The pronunciation is actually reasonable, that I sort of audio taped them and I just listened to it again and again. And so it's pretty reasonable. This is Nigel Miller. So he's a physician, a geriatrician, and he's the medical director of what's called the Southern District Health Board. They divide New Zealand into 21 district health boards. So he has a big job in that he allocates the resources for essentially the whole southern part of New Zealand. And he was telling me the story that he was seeing a patient for the first time. It was a frail, older Maori man who was accompanied by his children. And so Dr. Miller did the history and the examination, and then he said, well, here's what I think's going on, and here's what I suggest we do, at which point one of the daughters cut him off and said, who are you to tell us what to do? Who are you to tell my father what to do? You don't know my father. You don't know us. So who are you to be so presumptuous? So Dr. Miller, to his credit, he basically stopped for a moment, was silent, and then said, well, you're right. And then he told them his mihi, and that was the start to their relationship. So I think that for talks on equity and disparities, it helps to know a little bit about the speaker and the audience, in that it is an issue where if we're going to really make progress, we need to have honest discussions, and we'll dive into that in more detail over the next hour. So I ended up writing this paper with 6 colleagues. It came out 2 or 3 months ago in a journal called Health Policy, basically comparing the two countries, what they're doing for health equity, and what are the common lessons learned that can inform both countries' approaches. This is the set of authors. We actually never, all 7 of us, met in the same place because they were scattered across New Zealand as well as one other in the US. The 3 folks on the left, those are Maori, so indigenous peoples. They were amazing. That I learned a lot about them, about equity, and I think I finally appreciate and understand the word colonialism now from their experience. So the goals for today's talk are to review what is known about how to achieve health equity. I'll share lessons learned comparing the two countries, and then I'll introduce the landscape of using payment and care transformation to try to achieve health equity. Specifically, I'll briefly define equity so we have a common definition for this talk. I'll give you a couple basic statistics about the two countries, provide a conceptual framework. We'll spend most of the time talking about these key 5 lessons learned, and then I'll end with a little bit about advocacy and leadership. Does anyone recognize the picture bottom right here? Any film buffs? It's a little bit before most people's times, but if you're a film buff, you might recognize it. It's a movie called The Piano, and so this is a famous scene from Black Sand Beach, where the piano arrives and it's on the Black Sand Beach. It's beautiful. So this is the World Health Organization definition, which I like. Equity is the absence of avoidable or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically. Health inequities therefore involve more than inequality with respect to health determinants, access to the resources needed to improve and maintain health or health outcomes. They also entail a failure to avoid or overcome inequalities that infringe on fairness and human rights norms. And so what I like about the definition is that, well, it talks about the basic differences, so inequities. It talks about health determinants, social determinants, and then it raises the issue of it being a moral issue and a human rights issue, health inequities. So this is the definition for the vast majority of the world. How many people have seen this exact slide before? About half the people. It's a classic slide. So you see equality, every man gets the same size box. Equity, people get the size box they need to see the game. So tall man doesn't need any boxes at all. Short man, one box isn't going to do it, as opposed to what's happening on the right. So people talk about, well, what's the reality? That some people are born with a 10-yard head start in the race, and some people are 10 yards behind. And so that's the joke about like George Bush being born with a silver spoon in his mouth. And then this last slide is where the fence is removed, and that's supposed to represent removing the structural barriers to health equity. People have pointed out that there's a number of problems even still with that far right picture. Anything come to mind? Like, why is it still problematic, that picture? Mm-hmm.
So you said why the far right picture is problematic?
What's that?
Why it's problematic?
Yeah.
Like, what if you get hit by a baseball? Isn't that what the price is for?
Well, I guess, you could get hit by a baseball, although probably that far out, you're in pretty good shape compared to people closer in. What's the equity issue, though?
The inequities are still there.
What inequities?
They're not seats.
Right, there's 500 yards away as opposed to in the good seats, as one example. So they still aren't there. Anything else? Like this audience should very well get it, just looking around. Something else that's visually obvious.
Still different sizes.
Well, some people are born tall, some people are born short. That maybe if they were variant, like they're not in good seats, they're not playing the game. That's a good one. Yeah. And they are all three are Y chromosome. Man, we're the woman. Yeah. And let me say up front that I had a great time in New Zealand. I like the people a lot, but neither country really is the model you want to use for equity. Commonwealth Fund, they rank the 11 Western countries for equity. Aotearoa, New Zealand, number 8. U.S., dead last at number 11. So Aotearoa means the land of the long white cloud. It truly is a beautiful country. It's the North Island and South Island, and as you see from the map on the left, it's a long ways away. It's like doing like the travel delays and all, it's like over a day from door to door. It's a long ways away. I spent most of my time on the southern island, the city there called Dunedin, which is like their university town. So, of course, many fewer people in New Zealand than U.S. New Zealand's the size of Colorado. And then the distribution of minority populations is quite different. So 15% Maori as opposed to about 2% American Indian. So much more visible in New Zealand. 12% Asian, 7% Pacific peoples. If anyone's ever been to Auckland, you really get that flavor of like the Pacific Rim in terms of the Asian and Pacific peoples' influence. And so here's me surrounded by some of the 400 freshmen, so you get some sense of like, the demographic makeup of the folks. They're great students. And so here's a very simple conceptual model. So you see in the middle, or see at the far left, you have government and private policies. In the middle, they impact then the healthcare system, the integration of healthcare system with social services, and it's also terms of health. On the far right, you're trying to impact health equity. You see around there are three big words, so culture, history, and values. Those are like just huge factors that sort of overlay everything and are just, oftentimes we don't think about them, but they're really important drivers, and that's actually one of the things that I took home for me the most. I mean, people talk about when you travel, whether in this country or if you do foreign travel, one of the main benefits is just seeing your regular daily life in a new perspective, and that's what this did for me, my time in New Zealand. This is a reminder that there are multiple levels of policy action. On the left, you're a person who lives in a community. If you have access to care, you become a patient in the right bubble, interacting with a provider within a healthcare organization. And above that, you have a policy superstructure. So the big one is money, so financing, so the reimbursement system. There's also things like regulations and then the accreditation systems for hospitals, as an example. Ultimately, at the bottom, affecting processes of care and outcomes. And just a couple more definitions so that too often we simplify things in terms of one dimension at a time, like gender or race or class. The reality is that we have all these multiple dimensions and they all interact in different ways. There's a harsher, more cutting definition of intersectionality, which I have become more appreciative over the past 4 years. Kimberly Crenshaw is an African-American feminist, and her definition is the combination of intersecting systems of oppression that perpetuate discrimination and disadvantage based on factors such as race, class, sex, and gender identity. So I think as we go through this Aotearoa New Zealand example, you'll see how it plays out in terms of some of the Maori examples. So the first lesson 1 of the 5, is that, really for the US, the question whether we have our national cultural values appropriately balanced. There's a very famous quote from Peter Drucker, who's a businessman, culture eats strategy for breakfast. And what he meant was that if you're a business, you could have wonderful tactics, wonderful strategies, but if they didn't align with what the culture was at the company, culture wins out. The strategies wouldn't work. So think about that. What is the culture here at SSA? What's the culture at the University of Chicago? Hard to get things done if they're not consistent with the culture. So how does this play out? So culture, history, values. So this is a picture of Dean Joe Baxter, who's the Dean of Maori Affairs at the university I was at. She has 2 pieces of art in her room. This is one of them, this ragged piece of paper, which is a replica of the Treaty of Waitangi. So it represents how important this document is to her. And the Treaty of Waitangi, signed in 1840, is perhaps the seminal event in Aotearoa New Zealand history. What happened was that there were 400 Maori chieftains who signed a treaty with the British Crown. Now, the Maori translation of the treaty, the chiefs maintain their power, their sovereignty, their leadership. Now, strangely enough, in the English translation of the British have, the Maori chiefs give up their sovereignty, they give up their leadership, they give up their rights. So you can imagine this led to all types of conflict. And then the history is very similar to the US, where there was then a series of land wars, killing the Maori, confiscation of lands. The difference, though, is that the way I would word it is that there's almost a sense of collective national guilt to what was done to the Maori that we don't really sort of have here in this country. So the closest, so here for example, this is the National Museum in Wellington, which is their capital. So you see this big sort of like wall-size wording of like the Treaty of Waitangi there. And there's this plaque at the bottom that says, at the very last paragraph, that it was ragged because the original was damaged by fire, eaten by rats, damaged by water. So this last paragraph says, for many, the treaty's appearance parallels this past neglect in the life and law of the nation, but attempts are now being made to honor its promises. I would argue that here in the US we have a different perspective that's very much of an individual rights perspective as opposed to collective responsibility to a group. This is from '63, so the year before the Civil Rights Act of '64 passed, President Kennedy. We're confronted primarily with a moral issue. It is as old as the scriptures and as clear as the American Constitution. The heart of the question is whether all Americans are to be afforded equal rights and equal opportunities, whether we're going to treat our fellow Americans as we want to be treated. Discussing the right of African Americans to be served in a public restaurant, he declared, "This seems to me to be an elementary right. Its denial is an arbitrary indignity that no American in 1963 should have to endure, but many do." So you see all couched in the language of individual rights. The closest I could think of an American analogy is the debate about reparations for slavery. So back in, I think it was 2001, there was sort of this a right-wing conservative thinker sort of provocative writer who took out this ad in about 40, 50 college newspapers called 10 Reasons Why Reparations for Slavery is a Bad Idea. There's a lot of inaccuracies in the document. I also want to sort of share with you this one quote from the document. The black middle class in America is a prosperous community that is now larger in absolute terms than the black underclass. Does its existence not suggest that economic adversity is the result of failures of individual character rather than the lingering after effects of racial discrimination in a slave system that ceased to exist well over a century ago? So you have this current in American thinking about, it's not the system, it's the individual. If you're not doing well, it's your own fault. That only if you were sort of a better individual, you wouldn't be in this situation. There were a lot of rebuttals to this. Here's one from Ernest Allen Jr. and Robert Grissom. The descendants of that people's slaves continue to suffer the institutional legacies of slavery some 135 years after its demise. So, for example, biases in the criminal justice system, biases in the economic system. Racism continues as an ideology and material force within the U.S., providing blacks with no ladder that reaches the top. So there's that clash there. But you go to 2018, so reparations for slavery has little national traction. So nothing near like this, again, a sense of collective national guilt that you feel in New Zealand. And there's been a retrenchment in legal protections from some of these systematic ways of oppression and discrimination. So you've seen recently, like the recent election and like a year or two ago, the Supreme Court basically weakening the Voting Rights Act of 1965. So what's happening happened in Georgia, for example. So I recently went on a site visit to Minneapolis, and so interestingly, so in the U.S., the two cities that have the largest number of American Indians are Los Angeles and New York City. The city which has the largest density of urban African Americans or urban American Indians is Minneapolis. And so there's actually sort of a part of the town which is American Indian. When I went there, like 3 weeks before I went there, what was called the encampment was starting to happen. So right near one of the highway on-ramps, a tent city of about 200 largely urban American Indians had basically formed a tent city. Homeless, there's a high rate of substance disorder, economic lack of opportunities. So it was just sort of a vivid example of how today still American Indians, they're either marginalized on reservations where out of sight, out of mind, or in the cities, it's just really not a high priority for our country in terms of helping. So one of the best courses I took in college was a course on literature of the American myth. And every country has its mythology, so I'm going to share 3 or 4 with you of American ones. So this John Wayne, the rugged individualist, the frontiersman, get government off my back, the individualist. This Horatio Alger, so how many people here have heard of Horatio Alger? 1, 2, 3, 4, yeah. The older I get, the fewer number of hands go up. This is a famous series from like the 30s and 40s where there are these multiple books, but they're all basically the same story where some kid who's basically poor, down on his luck, comes from disadvantage. By the dint of his hard work and native talent and basically pulling himself up by his bootstraps, succeeds then in whatever he's doing, whether he's going to run the newspaper or become the big businessman or whatnot. So the same story. So again, it's sort of like, well, if you're only good enough, you would succeed. The melting pot, this is my parents' generation. So basically this is try to become as American as possible. So try to suppress any ethnic heritage you have and basically become like the generic American. And then there's Robin Hood. Okay, so who's clever here? So what's the problem with this slide on American mythology? So rob from the rich, give it to the poor. Robin Hood, the Legend of Sherwood, American myth. Is Robin Hood an American myth? It's an English myth. Yeah, so Robin Hood's in English. And it's because I really couldn't think of an analogous American myth for this concept. So these basically sort of translate to three theories of justice and ethics. So there's liberalism, liberty, individualism, limited constitutional government. There's communitarianism, the responsibility of the individual, the community, and the social importance of the family unit. And then there's distributive justice, the socially just allocation of goods in society. So the greatest of the 20th century American philosophers in this area is John Rawls. He was a philosopher at Harvard, very tall guy. And so he wrote this book where the key line is that the principles of justice are chosen behind a veil of ignorance. And what that means is that he thought that if you were to come up with the rules of society, the fairest way to do it would be before you knew your lot in life. Whether you're going to be born a man or a woman, rich or poor, black, white, Latino, Asian, educated, uneducated, powerful, marginalized. Because if you didn't know your lot in life, you would just try to make things as fair as possible. Whereas he argues, well, in the real world, whether it's explicit or implicit, this is biased to basically have people in power try to set up a system that preserves their advantage in the system. There's a historian from Brandeis named David Hackett Fisher who spent time in both countries. He wrote this book called Fairness and Freedom. And his stereotype is that on the whole, New Zealanders favor fairness, whereas Americans tend to favor freedom. My Maori colleagues would beg to differ in terms of like inequities they see. But I think comparing the two countries, his general thrust is on target. And so here's an example. So the safety net. So Aotearoa, New Zealand, this is what their national health insurance covers for all citizens and permanent residents. Details aren't important other than that it's a long list of things here on the left. It's pretty comprehensive. Whereas in the US, on the right there, still as of like 2 years ago, we were at like 9% uninsured. There's all the battles about the expansion of Medicaid under the ACA and all. We're still a long ways away. And keep in mind too, so neoliberalism, that's the term for this philosophy of like, well, you know, devolve to the individual, cut down government, make it smaller, put more responsibility on the individual. Both countries over the past 20 years have gone through a neoliberal phase. And actually it was there at a very good time because they were in the middle of a national election. And there was this phenomena that was also sort of seen in the US where, remember the stories that when people went to the rural parts of the country, you just saw Donald Trump signs, no Hillary signs. Same thing, when I was going to the rural parts of New Zealand, I did not see a single sign for the Labour Party. They were all signs for the National Party, which is the American Conservative Party. Bill English, their Prime Minister. But the point being that even though there was this neoliberal phase in New Zealand, just in the US, the floor of what they thought was acceptable for the most marginalized was such a much higher floor than this country. So it's just like, it's just the most jarring thing in terms of it's like a fundamentally different prioritization of values. Now, it's not to say that New Zealand has this figured out, that the issue then becomes like the overall underfunding of the health budget. So I actually got in this habit, like my ritual was I had breakfast in the dormitory, dining hall, and I would get the newspaper, and I started taking pictures every time I saw some story that had to do with like queues, a long waits in line because they didn't have an adequate budget. So you see, ultrasound waits, life miserable as surgery delayed, ambulance takes hour to reach stricken woman. So remember our friend Dr. Miller? Southern District Health Board rep to front, which I think means visit the dead man's family. So because of this delay in cardiac surgery, a patient died, so Dr. Miller went to basically visit and talk to the family. But it's a different type of framing of the debate, so more in terms of, well, societal allocation of resources as opposed to a blame the individual type of perspective. And you see it playing out today. So for example, like you're familiar with the Medicaid work requirements. So some of the recent conservative states expand the ACA, there's been a requirement for work requirements. You see that in the upper part of the slide here. The Kaiser Family Foundation, when they analyzed this, said most Medicaid enrollees who can work are already working, but could face barriers in complying with the reporting requirements. So in practice, it's an ideological policy which is essentially designed to cut people from the rolls. So lesson number 2, explicitly design quality of care and payment policies to achieve equity, hold the healthcare system accountable through public monitoring and evaluation, and support with adequate resources. So you look at the national language, the national health documents for both countries, and they both have very beautiful language about how the goal is health equity. So for example, at the very bottom here is New Zealand, timely and equitable access for all New Zealanders to a comprehensive range of health and disability services regardless of ability to pay. Notice at the very top, the Treaty of Waitangi. So again, their national health documents, just mentioned right up top, the Treaty of Waitangi. US, so this is the Healthy People 2020 statement. Achieve health equity, eliminate disparities, and improve the health of all groups. But here's the problem. When you look at the actual policies in both countries, it's really hard to find policies, any policies that are explicitly written and developed with the goal of trying to achieve health equity. So it's sort of like all talk and no substance. So here's an example. So New Zealand, again, is a little bit better than the US. So for example, when they allocate their national budget across the different countries, they have this thing called a New Zealand Index of Deprivation, where there are a variety of variables they use to basically try to adjust for the relative amount of economic and social deprivation in the countries to do the funding. Whereas like in the US, it's all very, very crude. So for example, like for uninsured patients, this is a thing called disproportionate share of payments, which is sort of a after the fact way of basically then trying to pay part of the share of the uninsured patients. Or the case measures that are used in the US system are very crude. So something that is crude is like if someone qualifies for both Medicaid and Medicare insurance, so it's a very crude marker as opposed to more detailed measures like this New Zealand Index of Deprivation. So what's an example is explicitly designing quality care measures to achieve equity. So this one stunned me, and this is one of the ones my Maori folks thought were like one of the best examples. 2007, immunization rates for 74% for especially the white settler population in New Zealand, 59% for Maori. So that's a 15% difference. Within 5 years, the gap had disappeared across the country. That's amazing. A 15% difference, 5 years, national disparities wiped out. How did they do it? Well, the Minister of Health made health equity a major priority. There was accountability. So there was quarterly public immunization scorecards where they ranked these 21 district health boards. So there was public shaming in a sense. There's collaborative approaches. So there was sharing of best practices, best systems, community outreach. And there were competitive approaches. So the public reporting where they compared these 21 district health boards, there were paper performance also. So it's not just New Zealand. So this is my favorite Chicago story for this concept. We've had the new regime in place for about 8 years now, but before then there was a very stable group of leadership in the hospital. And so the guy who was the chief financial officer had been there 15, 18 years. So every year he would go to each different department and give essentially the state of the finances talk to each department. And he also explained the strategy of the University of Chicago. So it turns out that a relatively small percentage of the patients in the hospital actually make money for the hospital and subsidize the rest of the operations. Any idea what percent of the patients that is? So Gene says 10%. Any other guesses? What's that?
5%.
Ooh, you got it, Colleen. Yes, 5%. 5%, and then the rest of the patients either lose money or else are roughly even. And so the strategy at that time, and as part of the strategy now, is basically to try to increase the number of those 5% patients coming into the University of Chicago. And these are the patients you might expect. It's the high-tech stuff: organ transplantation, orthopedic surgery, cancer chemotherapy, gastrointestinal procedures. So they're basically trying to get more patients from northern Indiana and the western suburbs and south further off who are well insured with these conditions to come to the university. I heard him give this talk like 3 times. So I raised my hand and said, hey, you know, isn't it a little risky basing the strategy of the University Medical Center on only 5% of the patients? And he said to me, well, you smart aleck, Marshall, someone asks me that question every year. And my answer is the same every year. What has changed in our state or national policy that would make me as a rational person change the strategic policy? And I had to actually shut up because he was right that, you know, in some ways the university was just doing what like a business does in terms of like playing by the rules of the game. And the rules of the game was to make a profit and subsidize education and the other service lines. You know, you try to then increase the number of these coordinary care patients coming into the system. However, you know, the regime changed 8 years ago. And so when Dean Pulaski came, he cleaned house. 90% of senior management turned over. And there has been, I think, honestly, much more interest in the South Side population, much more interest in population health. And I think it's probably a couple different things. One thing, I do think that part of it is the right thing to do. And Dean Pulaski, you ask him about his background, it's very interesting. He grew up in South Africa at the height of the apartheid era. And so he gives these stories as like a student being part of the protests, and like the government would actually film like the crowd, so they would have a record of who was at these different protests. But I'm not so naive to believe that that's the one what's driving Dean Polonsky. The business case had changed, that they were starting to become more of an incentive to start thinking about population health, the shift from fee-for-service, volume-based payment to global payments, population health, or, for example, a community needs assessment. So for the nonprofit status of the university, you have to do a community needs assessment and demonstrate community benefit. The nonprofit status is worth millions to the university each year. And we'll skip that. So how does this start playing out in policy? So the National Quality Forum is a multi-stakeholder group that involves a lot of key stakeholders, so like health plans, healthcare organizations, professional societies, consumer and patient advocacy groups, among others, unions. And they basically come up with like the national quality metrics that are used, for example, in the Medicare and Medicaid programs. So back almost a year ago, a year ago, they came up with this health equity roadmap report. And they have these so-called 4 I's: identify priority disparity areas, implement evidence-based interventions to reduce disparities, invest in health equity performance measures, and then incentivize the reduction of health disparities and achievement of health equity. And they thought that the 2 domains of equity were ready for prime time in terms of them being used in like paper performance schemes. They thought, for example, the measures of access to care and quality care were good enough that you could use them for reimbursement. The bottom 3 they thought were not ready for accountability but could be used for quality improvement purposes. So does the University of Chicago has a structure for equity in the health system? Is there a culture of equity at the university? How strong are the partnerships with the community, for example, and collaborations? I'm going to skip to the incentivization recommendations. There were 10. I'm going to collapse them down to 5. One was accountability. So the so-called stratified equity outcome measures. So for example, you take a measure like blood pressure control, you see how white patients are doing, African-American patients look for disparity and reward based upon various ways of reducing disparities. You could redesign payment models to support health equity. And I think about it almost in like 3 different buckets here. So there are things like infrastructure, and there's now this shift to global payment, capitated payment. Some of the community health workers, which is a lot of good evidence for them being effective, typically aren't paid for in the fee-for-service system. So you have to find some way to utilize that global payment to make its way to funding these type of infrastructural things that can reduce disparities. You can also incentivize specific things. So for example, if your goal is to reduce breast cancer disparities, it may be reasonable to actually do pay-for performance for increasing mammography screening rates in underserved populations. And then it's integrating health and social service. So you all know very well just how much powerful social services are in terms of equity issues and the importance of integrating those funding streams. The safety net needs special attention, so like federally qualified health centers, for example, or West Georgia Hospital. We need more demonstration projects in terms of these care transformation and payment programs. And then last is that we need to look at different economic perspectives. I think typically like in academia or like in the wider view world, we take a look at the societal cost-effectiveness analysis, which is very important. But equally important is the business case perspective from, for example, a University of Chicago. Because again, unless the incentives align, it's not going to be sustainable for the University of Chicago to do a big equity initiative, or institutions that may not particularly care about equity won't be motivated to take it more seriously. I'm going to skip this time. We have a Robert Justice Foundation called Finding Answers, our website, solvingdisparities.org. And so we do have also this, like what we learned over 14 years, this so-called roadmap to reduce disparities. And the sobering thing is there's no magic bullet, which maybe not surprising. So people want to have a simple solution. There's no simple solution. And the reason is that it takes a systematic process where for it to be the true change at whether it's University of Chicago or any organization or area, there has to be the awareness of equity issues and then prioritizing it. So it's one thing to basically sort of see equity, it's another thing for the institution to take it seriously. You have to tailor the solution to local organizational and patient contexts. It's very hard to have an off-the-shelf solution that's going to work everywhere. It's got to be an iterative quality improvement process, then addressing the specific barriers and facilitators of change using principles of implementation science. So when you say this to the groups, they don't like it. What they want to have is a menu of evidence-based interventions, at least as a starting point, which they can think about in terms of tailoring to their own particular purposes. So here's our 6 steps to the roadmap. A lot we've already gone over so far. Recognizing disparities, committing to working on them, implementing a quality improvement infrastructure and process. So it's supposed to have a one-off, like you could do your nice intervention, but if it's not baked into like the guts of like just how the institution does this work to improve outcomes as a whole. It's just going to be your own, personal project that then dies when it ends. Making equity an integral part of quality. Too often, the people who work in quality are different than the people that care about equity, but they really are sort of seamless and really need to be integrated. Implement, evaluate, adjust your intervention, and sustain them. So some of the financial things we've been talking about. The other sobering thing is that when you review the literature, so we reviewed the literature of like 400 disparity interventions, there aren't a lot of common themes about what works for reducing disparities. The closest we can come up with multifactorial interventions that attack different levers. Think back to that conceptual model, that the different bubbles and all that. You got to attack all the different barriers. Culturally tailored approaches better than generic one-size-fits-all approaches. A lot of good evidence for team-based care. Often like a nurse-led care. Any nurses here? A lot of good evidence for nurse-led care. Not surprisingly, involving families, community partners, robust literature for community health workers, and then interactive skills-based training is better than what I'm doing now, which is didactic lecturing, which is passive. So I like this example of like, a culturally tailored Maori example. So for the youngest children, the biggest disparity is in rates of sudden unexpected death. And the country initially did a generic one-size-fits-all education program, but the disparities remained. So they started thinking about like culturally tailored approaches. And so one approach is the wahakura, which is this traditional flax woven basket. And they compared basically using that woven basket versus the standard Western bassinet. And they created these interventions where master flax weavers would create these wahakura and then teach mothers about safe sleeping practices, decreased smoking, and breastfeeding. And they was found then to help decrease the disparities that the mothers who participated talked about, like social cohesion and the cultural pride, and this in conjunction with the same messages in terms of like the safe sleeping practices, the breastfeeding, the decreased smoking, and then the bassinet, which is culturally tailored, so more apt to use it, all help then to reduce these disparities. And so they're actually now re-rolling a national program using both generic approaches as well as culturally tailored approaches. Skip that. So lesson 3, addressing all determinants of health for individuals and communities with coordinated approaches, integrated funding streams, and shared accountability metrics across health and social sectors. So this should be very familiar to you here as SSA. So I alluded to this earlier. So healthcare maybe explains 10% of the variation in health. Social determinants, 30 to 40%. In this country now, there's been a lot of attention about like the so-called high utilizing patients, the ones that cost a lot of money, that keep on coming to the emergency department and coming back to the being admitted to the hospital. So there's interest in population health management. There's a documentary that was at the university about a month ago called What Counts, which talks about the work of Health Leads, which is a group that does some of this linkage of patients between healthcare and the social service sector. So I was on a panel, and one of the students asked me afterwards, well, what will it take to basically bridge this gap and address these social determinants? So it made me think. So my answer was that this is what I think is like, and I'd be curious what you guys all think, but this is the process of systematic change, that you didn't have pilot work and demonstration projects, so proof of concept. You may do, like, as a researcher, like an intervention that works. And typically you have like funding from like local foundations or demonstration type of projects. You then hope to develop and disseminate the model programs. It will take advocacy, local and national and state, in terms of then sort of influencing the policy, in particular the state and federal legislations that fund then this type of work, because the amount of funds required goes beyond what's going to be doable by a foundation, and basically it's to be baked into the reimbursement system. So what is that overall process? So what are the necessary ingredients for addressing social determinants of health? So creating the hubs and partnerships of the healthcare and community organizations, integrating the two, and then the robust funding streams. And we talked about grants and then the underlying reimbursement schemes over time. So that's what's required. You may have seen this before. This is so Bessie Bradley. She used to be at Yale. She's now the president of Vassar. So very famous study where it turns out like the vertical axis is percent GDP, and these are most of the Western countries. So it turns out the percent GDP across these countries is not that different. But when you divide it between how much of that is healthcare spending versus social service spending, the outlier is the U.S. That's the arrow. So you see that the black bar is the healthcare spending, so much higher percentage than the other Western countries in terms of compared to social service spending. And the way it plays out is that those countries that have the higher ratio of social to health spending have the better health outcomes for things like infant mortality, maternal mortality, low birth weight, and then this broad category of potential life years lost. So very powerful national data. So how do you replicate this in the US? Well, you have to have an entity that has a large enough population to serve, so like health plans, large health organizations, limited turnover of that population, so there's the incentive to basically take good care of them, so where prevention is rewarded instead of costly emergency and inpatient care. Just to highlight, so for those of you interested more, and Colleen and Gene are experts in this, I think the 4 states that are doing the most interesting things at a state level in terms of the Medicaid programs and the reimbursement systems are Minnesota, Oregon, Massachusetts, and then Maryland. They all have various forms where they're basically shifting to global payment, accountable care organizations, incentivization for basically decreasing hospital costs, decreasing the total cost of care. So this is where some of the best literature is in terms of the most innovative programs right now. We do have a new program called Bridging the Gap, Reducing Disparities in Diabetes Care. One of my colleagues, Monica Peak and I, we co-direct this program where it's trying to reduce diabetes disparities through care transformation, social terms of health, and then sustainability, and those different things there. And again, like some of the most interesting work is in like one of those 4 states. One of the best grantees we've seen so far is in Western Maryland, which is the rural Appalachian part of Maryland. But they're innovative, and because the financing system is supporting this, because there's the incentive to keep people healthy in the community as opposed to being admitted to the hospital, they got a chance to do it. So here's one of our site visits, also the Minneapolis one, where example of what they're doing, so that they're working with a couple clinics as well as some of the local health food resources there. So they're launching this little like healthy food and free food campaign, so they're going to advertising the bus lines and all. One example is the American Indian part of town I mentioned, that there's a lot of work trying to sort of partner with community development. So we had actually this particular part of the meeting at a American Indian-owned coffee shop. Right next door was this art gallery, which serves a social cohesion function too, in terms of a voice for the people, and then a hub then for the artists in terms of community and livelihood. Lesson 4, share power authentically with racial ethnic minorities and promote indigenous peoples' leadership and self-determination. So this is something I didn't know too much about. My Maori friends, they love this system, and so they told me about it. So this is NUCA. It's a system in Alaska, so where the Alaska Native people actually own the healthcare system, not the federal Indian Health Service, but the Alaskan people own it. So they are customer owners who have tailored the system to meet their needs through a self-determined process. So you hear these words like sovereignty, self-determination a lot when you talk to indigenous peoples. Very important to them. Key principles here were shared responsibility, commitment to quality, continuous improvement, and family wellness. They have prepaid care, they do rural outreach, and they have good outcomes. They basically have been able to basically decrease costs, utilization, and improve quality. So, and when I've asked about it for people who have been there, they confirm that it's true, and it's a really good system. 5, so here's where it starts to get trickier in terms of some of the conversations. Well, I think this is a common conversation you have at SSA, so probably not that dissimilar to the conversations you already have. Has sincere, honest discussions about structural racism, colonialism, white privilege, and implicit biases, ensuring that policies and programs explicitly address root causes. So I actually have a vivid example. So this paper, the one I mentioned, was published like 2 or 3 months ago. One of the reviewers, the first set of reviews, one of the reviewers said, the language used is at times moralistic, for example, calls for authenticity and honesty in the text. Share power authentically. Have sincere, honest discussions about structural racism. So our response was, well, yes, equity is a moral issue. So you remember the first part of the talk. And these words objectively capture the reality. So again, like my Maori friends, they were particularly tough about this and sort of like insistent upon some of this tougher language. And you know, this is actually what we said in the response to the reviewer. Racial ethnic minorities and indigenous peoples often mistrust majority institutions because of a history of discrimination, oppression, broken promises, and egregious ethical violations such as experimentation on them, like in our country, Tuskegee. So this is one of my aha moments that I had in New Zealand. So power is the issue. So I already knew the first bullet. So it's control over resources, that's part of the issue. What was new to me was more appreciation for bullets 2 and 3. Control over the historical narrative. So you remember like the two very different historical narratives about the Treaty of Waitangi, and then control how the issue is framed. This one is quite relevant for us today in our current sort of partisan environment. 1993 documentary about the Treaty of Waitangi. Jim Bolger was the Prime Minister at that time in New Zealand. How do we make this founding document work for New Zealand? It really has to work for both of us, Maori and non-Maori. Not to have it as something that forces us to look back, but really forces us to look forward. So on one hand, you could say, well, he's just being constructive. Let's move ahead and let's think of what we can do, think positively moving ahead. Or you could say that he's basically whitewashing history, not having the look back at like how we got here, what was the historical precedent, what happened between 1840 and the present in terms of the structural barriers and the colonial aspects that have led to the Maori, non-Maori disparities. It was like my last week I was in New Zealand. So again, I was there for like 3 months. And so I had gotten to know, I don't know, 50 or 60 of the students pretty well, and some of them, including some of the Maori students. So I asked some of the Maori students I got to know a question I couldn't have asked them in the beginning. I asked them, well, what do you think of your white classmates? And so what they said was that they really liked their white classmates. A lot of their friends are white, good people, nice people. They very much liked their white classmates. They did all say, though, that like also the thing that their white classmates had the hardest time understanding was the issues of the structural racism and colonialism. How, for example, like why, because the Maori tend to go to inferior public schools, most of the Maori have to do an additional year of like basically basic coursework before they can start entering like the pre-medical curriculum, or if they have to do a lot of work to like, earn wages, they do like other extracurriculars that make the CV look more interesting. So they said that that was pretty common in terms of that was a hard thing for them to be able to explain in a way that their classmates would understand. So let's just the U.S. We talked about values, that cultural strategy for lunch. So all of these like payment stuff I've been talking about all go for naught, or the quality improvement stuff go for naught if the values don't align. I'd argue that in our country we tend to underplay the values of communitarianism and distributive justice. I won't leave time for question and answers. I'm going to sort of skip this part and end with just a little bit about advocacy and leadership. This is like an iconic picture from the 60s, the student protests in Japan in the 60s. So I sort of like all this sort of embedded in this particular image. So maybe it was like 2-3 years ago. So it was like the height of the Black Lives Matter movement. And I was troubled when this was all happening. And the reason why it was troubling to me, of course, there was the Laquan McDonald Institute, which of course was horrifying in terms of like the cold-blooded murder of African-American youth by the police. But the other reason why it sort of gave me sort of like some tension is that I'm not sort of a march in the streets with the bullhorn type of person. I tend to be sort of work within the system and try to influence policy that way, research and the committees and whatnot. However, at the same time, I saw how valuable and important the Black Lives Matter movement was. That, frankly, if it wasn't for the Black Lives Matter movement, there wouldn't be nearly as much discussion and progress as we have been starting to make in terms of police brutality and this type of institutionalized racism within the criminal justice system. And so I ended up like writing this essay where I basically was trying to sort of reconcile two things, like what I called movement advocacy, basically sort of in the streets type of action. But at the same time, what I knew from like being a clinician or working with the systems, that you have to have people's trust if you're going to basically make the change at the local level. That doesn't do much good if I tell Colleen, oh, Colleen, you're a racist. Now let's work together and improve the equity here at the University of Chicago. Actually, you're really magnanimous, but for most people, it's not particularly the greatest way to sort of start off a collaborative discussion. As well as and I've talked to a number of people about this recently, that it's really important to make sure that everyone feels included. So I've had talks, for example, with older white men who very much want to be aligned in the cause for equity. And they say, you know, like talks can be given in a way that either make them feel, you know, empowered and welcome, or in ways that feel exclusionary. And, you know, it's a big battle. You got to have all the allies and sort of a support you can get for this. So I wrote in this essay, I believe movement advocacy can break down ingrained structural barriers and policies that impede health equity, while clinicians, healthcare organizations, and advocates build trusting relationships and resolve conflict with mutual respect and honesty. We must combine advocacy and relationship building to end disparities. Achieving health equity will require policy changes and personalized clinical care and organizational transformation that are dependent on goodwill and trust. It gets back to that slide I mentioned. Remember I talked a little bit about what's required in terms of the process of change for achieving equity. And so some of it is political, some of it is like research in terms of ideal models, and some of it is sort of advocacy. Yeah, the amazing thing is that it's not as distant as you might think. So New Zealand, for example, is a small country. Like, it's 5 million people. And so like my second week there, I was just walking the street and I ran into the guy in the upper right who was the member of parliament for the city of Dunedin. And so when Labour won, so Labour, Jacinda, you may remember her in the news, she's like 38 years old and she had a baby recently. So this is like one of the few most rare national leaders that had a baby in office. David Clark, again, that member of parliament, he's now the health minister in New Zealand. And so, so it's a small thing. Or I ended up having like 2 minutes with Bill English. I gave him my 30 seconds to spiel on health equity. And it actually was my wife. She's a celebrity. That was the reason why we got to meet him. But I used my 30 seconds to try to push health equity. Yeah. Mr. House, spent time with those folks. And then, again, just to give you hope that, like, so 3 weeks ago I was in Idaho doing these site visits for one of our grant programs. And so, again, in the middle of the election, so you saw all these signs for the lieutenant governor, Republican conservative, keep Idaho conservative. But at the same time, you saw these signs, yes on 2, Idahoans for health care. Idaho is one of the 3 states that had up on the ballot expansion of Medicaid. There were 3 red conservative states that had it up on the ballot, and they all passed. And so, in Idaho, it passed 2 to 1, like 60% or so of the population voted for expanding Medicaid. So even in a very conservative state, it shows that there are ways to message in ways that, you know, are the right ways. Now let's end with this quote, that leadership matters. It is our professional responsibility as clinicians, administrators, policymakers to improve the way we deliver care to diverse patients. We can do better. So thank you very much.